Assalamualaikum and hi everyone. Today our group will present about Pompe disease, which is one of the inherited disorder under carbohydrate metabolism disorder. Before we begin, these are the group members involved in preparing this presentation. Each member contribute to different section of the assignment. Introduction to Pompe disease. Pompe disease, also known as glycogen storage disease type 2. Is a rare inherited metabolic disorder caused by mutation in GAA gene. This mutation lead to deficiency of the enzyme acid alpha-glucosidase. This enzyme responsible for breaking down glycogen within lysosome, especially in skeletal, cardiac, and respiratory muscle. Pompe disease can be divided into two main forms, which is infantile onset Pompe disease, which appear during infancy and is usually more severe, and also late onset Pompe disease, which can develop from childhood to adulthood. Although Pompe disease is considered rare, it affects individuals worldwide with an estimated incidence of approximately 1 in every 40,000 births. This disease occurs in all ethnic groups and often underdiagnosed due to variable symptoms. The disease has a significant impact on human health. Patients commonly experience muscle weakness, which affects daily activities. In some severe cases, patients also will face respiratory complications like hard to breathe and lung failure. Some infantile onset cases, cardiac failure may occur, which can be life-threatening if it left untreated. Pompe disease also affects patient quality of life by limiting daily activities and increasing dependence on long-term medical care. Therefore, early diagnosis and appropriate treatment are essential to slow disease progression and improve patient outcome.
Let's start by looking at how our cell normally process glycogen for energy. While most glycogen metabolism occurs in the cytosol, a small portion of cellular glycogen is continuously transported into the lysosome via a process called autophagy. Once inside acidic environment of the lysosome, this glycogen must be break down. This breakdown is performed by an essential enzyme called acid alpha-glucosidase, commonly known as a GAA. The GAA enzyme works by catalyzing the hydrolysis of the both alpha-1,4 and alpha-A16 glycosidic bonds. This process breaks the complex glycogen polymer down into molecules of free glucose. Finally, the free glucose is released back into the cytoplasm. From there, it enters the glycolysis pathway to produce the ATP, providing vital energy for the cell. Now let's zoom into the exact biochemistry of this process. The production of the GAA enzyme begins at the chromosome 17, especially at the 17q25.2, q25.3 locus. The GAA gene is transcribed and translated to produce the active acid alpha-glucosidase enzyme, which functions as a lysosomal hydrolase. So to summarize the reactions happening inside the lysosome, our substrate is the glycogen stored within the lysosome. Then our enzyme is the GAA, also known as acid maltase. The reaction itself is the hydrolysis of the alpha-1,4 and alpha-1,6 bond. The primary product is the free glucose. As a critical cellular function, this glucose exits the lysosome to power downstream metabolic pathway, ultimately generating ATP and fueling the cell. Unfortunately, disruption to this pathway lead to severe clinical outcome, such as a Pompe disease. The GAA gene, which has an autosomal recessive inheritance pattern, can suffer from variety of genetics error. In fact, researchers have identified more than 560 pathogenic mutations in this single gene. This mutation can negatively impact the protein at the multiple stage. They can disrupt the RNAs placing impair the protein folding, alter the enzyme processing, interfere the lysosomal trafficking, or directly destroy the catalytic activity of GAA. Ultimately, all of these mutations result in reduce the synthesis of the activity of the functional enzyme, causing the glycogen to dangerously accumulate within the lysosome. So looking at the table, we can see how specifically mutation dictates the clinical presentation. For the example, the C.32-13TG splice site mutations leave some residual enzyme activity, and it's the most common cause of the late onset of the Pompe disease. So the conversely, friendship of mutation like C.525DELT or nonsense mutation like C.2560CT severely reduce or eliminate enzyme activity, resulting in severe infantile onset disease. In short, the clinical severity of this disease directly depends on the percentage of residual enzyme activity remaining after the mutations.
My name is Tilakraj Adityan and my matrix number is AN240155. So today I'll be talking about the biochemical pathways and molecular mechanism of Pompe disease. So we can talk about this in three aspects. The first aspect is the mechanism by which mutation alters the enzyme structure and function. What does this mean? Okay, how does the disease alter the enzyme to become something that is destructive to the body? Okay, so there are four main mechanisms of mutational impact. Number one is truncation and non-synthesis. Okay, under this, what happens is it creates a premature stop codon. Second is misfolding and ER retention. We call it missense. It destabilizes the 3D protein conformation. And number three is defective trafficking missense or splice site. This happens and it will disrupt the addition of mannose 6-phosphate M6P targeting tags. Number four is catalytic inactivation, missense at active site, where the enzyme folds and targets correctly but alters active site geometry. Okay, the second aspect is consequences of pathway disruption at cellular and systemic level. Number one is lysosome engorgement. Why? There is too much of glycogen entering the lysosome, but there is no way out. Second is lysosome rupture. This is due to the increased mechanical stress because of the increased amount of glycogen entering the lysosome. Number three is autophagic buildup. Okay, what happens is this is the hallmark of Pompe disease. Now, autophag- autophagic is a cellular recycling mechanism. What happens is because of the increase in glycogen levels, this fails to work properly and the cells will start deteriorating and killing itself. At a systemic level, the consequence is skeletal muscle wasting, cardiomyopathy, and another effect is respiratory failure. So, skeletal muscle wasting, cardiomyopathy, and respiratory failure all occurs because of the failure of the cells to function properly. Now, skeletal muscle wasting is because the skeletal muscles will have too much of glycogen and it will start to deform. As for cardiomyopathy, the arteries will become too thick and cause dysfunction in pumping out blood. Respiratory failure will also uh, be caused because of the way the lungs and the cells in the lungs and the esophagus becomes too thick and fails to function properly. Third, we are going to look at the correlation between biochemical defects and signs and symptoms at different life stages. Okay, the first type is infantile offset (IOPD). Okay, this is less than 1% of residual enzyme activity, nearly absent. Okay. The primary biochemical defect for this type of Pompe disease is the absolute block in lysosomal glycogen clearance, rapid unchecked cellular destruction in cardiac and skeletal muscle. What are the symptoms? Is number one, severe cardiomegaly, called as balloon heart on X-ray, leading to early heart failure. Second is profound hypotonia, known as floppy baby syndrome, where babies cannot lift their heads or sit up. Number three is macroglossia, enlarged tongue due to glycogen buildup. Now, this infantile offset IOPD, when it occurs for babies, the life expectancy is only uh, about 18 months, because this can be very fatal to the baby, mainly because of the heart failure. Okay, number two is the late onset disease. Okay, for this, the residual enzyme activity is from 1 to 30%. Okay, it's partially active, partially deficient. Okay, now what is the primary biochemical defect for this? It is slow, insidious accumulation of glycogen over the decades. Okay, the skeletal muscles are severely affected in this process. What are the symptoms for these type of Pompe disease? Number one is proximal muscle weakness. Your muscle will feel very weak. There will be difficulty climbing stairs, difficulty doing simple tasks, for example, rising from a chair or lifting objects. Number two is diaphragmatic weakness. Okay, the first severe symptom is one of these. Why? Because they have sleep apnea, morning headaches, and also early onset respiratory failure despite still being ambulatory. Now, this happens to adults, and Pompe disease, the main hallmark, like I've told before, is the destruction of cell. Now, respiratory problems are the main things that adults need to look out when they have Pompe disease. Even though Pompe disease is only 1 in 40,000 cases, is very rare, but it is not impossible.
Good day everyone. My name is Tilageshwaran, son of Mohanasudaram. My matrix number is DN250003. Now let me continue from my part of presentation, which is diagnostic method and biomolecular technique. The overview of the diagnostic pipeline is clinical triggers, primary screening, and gold standard. There are three. The first one is identifying floppy baby syndrome, IOPD, or progressive proximal muscle weakness, LOPD. Second one, primary screening, is the initial non-specific test, example like elevated creatine kinase levels or balloon heart on X-ray. The third one is the gold standard. Confirmation requires demonstrating acid alpha glucosidase (GAA) deficiency and or identifying pathogenic mutation in the GAA gene. Let us look at the first biochemical assay, which is the measuring enzyme activity. The technique is known as fluorometric enzyme assay. Its application measures the activity level of the GAA enzyme in dried blood spots (DBS), skin fibroblasts, or muscle biopsy samples. Strengths: highly sensitive for infantile onset Pompe disease (IOPD), where activity is less than 1%, relatively fast, and serves as the primary confirmatory test for newborns. Limitations: pseudodeficiency alleles can lead to false positive. Second one is the less sensitive for late onset LOPD, where residual activity 1% to 30% may overlap with normal ranges. Now let us see the second biochemical assay, which is molecular genetic analysis. This technique is known as polymerase chain reaction (PCR) and next generation sequencing (NGS). Its application is specifically targets the GAA gene located on chromosome 17q25.3, used to identify specific mutation types: missense, nonsense, frameshift, or splice site. And the strengths are: definitive diagnosis identifies the exact molecular mechanism, misfolding or catalytic inactivation. And the second point is essential for carrier screening and prenatal diagnosis within affected families. Its limitations is higher cost and requires specialized bioinformatics for data interpretation, and variants of unknown significance (VUS) can make clinical interpretation difficult. Now let us look at the third biochemical assay, which is metabolite profiling biomarkers. Technique is known as liquid chromatography tandem mass spectrometry. The application is measuring urinary comparative evolution of methyl glucose tetrasaccharide X, a byproduct of systematic glycogen accumulation. Strengths: non-invasive urine sample, excellent for monitoring treatment effectiveness of enzyme replacement therapy (ERT) over time. Limitation: not specific to POMP disease, can be elevated in other glycogen storage diseases. Second point is reflects the total body burden of glycogen rather than specific tissue damage.
Good day, doctor. My name is G11 Manimaran and my matrix number is CN240340. Pompe disease is a genetic disorder caused by a deficiency of the enzyme acid alpha glucoside GAA, which is responsible for breaking down glycogen inside cells. When this enzyme is absent or not working properly, glycogen accumulates in muscle cells, leading to progressive muscle weakness and, in severe cases, breathing and heart problems. The main treatment is enzyme replacement therapy (ERT), where patients are given the missing GAA enzyme through regular intravenous infusions. This treatment helps reduce glycogen buildup, slow disease progression, and improve symptoms. However, it does not correct the underlying genetic cause of the disease, so it cannot provide a complete cure and must be continued throughout the patient's life. Gene therapy is a newer treatment approach that targets the underlying cause of Pompe disease rather than just the symptoms. Instead of repeatedly supplying the missing enzyme, it introduces a healthy GAA gene into the patient's cells so they can produce the enzyme themselves. Once the cells receive this gene, they can gain the ability to continuously produce the GAA enzyme needed to break down the glycogen. This may reduce or even eliminate the need for lifelong enzyme replacement therapy. However, it is still in the experimental stage and still being studied in clinical research to confirm its safety and effectiveness. Gene therapy uses modified viral vectors because viruses are naturally efficient at entering cells. Scientists remove harmful genetic material from the virus and use it as a safe carrier to deliver the healthy GAA gene into the body. In the in vivo approach, the vector is injected directly into the bloodstream and travels to organs such as the heart and muscles to deliver the gene. In the ex vivo approach, the patient's cells are collected, genetically modified in the lab, and then returned to the body so they can produce the missing enzyme. Currently, these treatments are still in early research and clinical trial stages, and more studies are needed to confirm their long-term safety and effectiveness.